G'day and welcome to Follow the Money, the Australia Institute's podcast demystifying the big economic issues in Australia and putting them in plain English. I'm Ebony Bennett, Deputy Director at the Institute, and today we're bringing you more guests from our Economics of a Pandemic webinar series.
Northern Territory will shut its borders in an effort to prevent a COVID-19 outbreak in remote Indigenous communities.
The Northern Territory will implement strict border controls for all access points by road, rail, air and sea.
The bottom line has to be that we protect our people, protect our communities, protect our leaders.
That could wipe a great number of our people out just if it got into any part of our communities.
We got to treat everyone outside our home like a lumbra, like a poison cousin. The only way to look after our mob is to stay like your own house with one mob.
I know lots of family are really worried about this disease.
With the coronavirus, it is really important that we take care of our community and our elders in particular.
Whilst coronavirus is happening, hanging out with brother boys and sister girls isn't appropriate.
It's up to you to do your part to keep our mob and community safe from coronavirus.
In this episode, we're talking about the huge success of the Aboriginal-led health response to the pandemic, with Lesley Nelson, CEO of Southwest Aboriginal Medical Service, Francine Eads, Chair of the Derbarl-Yerrigan Health Service, Professor Sandra Eads, Dean of Curtin Medical School, and Associate Professor Dan McCauley, who's the Director of the Centre for Improving Health Services for Aboriginal Children at Edith Cowan University, along with our Chief Economist Richard Dennis. And to properly introduce them, we welcomed Professor Fiona Stanley, epidemiologist and patron of the Telethon Kids Institute, who was named Australian of the Year in 2003. Professor Fiona Stanley is a vocal advocate for the needs of children and their families, and we were delighted that she could join us today. This was recorded live on Thursday, the 25th of June 2020, and things may have changed since recording. Thank you, Fiona Stanley.
Thanks so much, Ebony, and thanks for setting this up. I'd also like to acknowledge that I'm actually in Melbourne on Wurundjeri country today, and I always like to acknowledge the past and present injustices, the fact that the land was never ceded, and also acknowledge any First Nations who are on the webinar. And of course, I'll be introducing my Noongar colleagues from WA soon. This is a really important issue, as you said, for us. COVID-19 is a huge concern to First Nations in Australia. In the H1N1 flu epidemic in 2009, First Nations had a higher rates of disease. There were more hospitalisations and deaths than all other Australians. Aboriginal and Torres Strait Islander people tend to have higher rates of chronic disease. Many live in poor conditions with extended family, all of these being risk factors, and in poverty, which is another risk factor for everything. And the concerns were not only for the remote dwelling Aboriginal and Torres Strait Islanders, but for those in urban centres, because the vast majority of Aboriginal people actually live in urban centres, 80% of them live in urban centres. So what happened? These results are quite extraordinary, and I think we should be shouting them from the rooftops, so I hope that the Australia Institute's a good rooftop. Only 60 cases nationwide. If we had the same risk, if First Nations had the same risk as non-First Nations, we would have had 215 cases. But of course, we would have expected more than that because of the high risk. None were in remote and very remote communities. 15%, only 15% were hospitalised. None in intensive care. There were no deaths. And the latest data that we have shows that there were absolutely no cases that were caught in the Black Lives Matter protests. So they were conducted really well by Aboriginal leaders there. Now, this is a much better outcome than non-Indigenous people in Australia. The gap is completely reversed, and it's better than any other Indigenous nation internationally. So how did they do it? You know, what does this success mean for future Aboriginal and Torres Strait Islander health services? And so it's just my real pleasure to introduce you four outstanding experts, health experts, all from WA. The first is Lesley Nelson, who is the CEO of Southwest Aboriginal Medical Service. Lesley has a huge experience in health services administration and has the most amazing plans for a holistic, culturally enriched health and wellbeing service in Bunbury. So very warm welcome to you, Lesley. Then we have Francine Eads, who is a nurse and epidemiologist, who is currently the chairman of the board of Durbal Yerrigan, which is the Perth Aboriginal Medical Service. And Francine, again, has a huge experience, particularly in research as well as healthcare in various jurisdictions. Then Professor Sandra Eads, who has come just recently from being professor at Melbourne University, but is Noongar, and has come back to Western Australia to be, wait for it, the first Indigenous Dean of any medical school in Australia, and she has become Dean and Head of Health Sciences at Curtin University. And last but not least, Dr. Daniel McCauley, who is the Director of Kurrangkong Purdichikadjin at Edith Cowan University, which is the Aboriginal Centre there, and has significant responsibility for the Aboriginal Health Infonet. So that might be something that people are interested in. So without further ado, it's my huge pleasure to introduce these group to you and ask Lesley to kick off. How did it happen? How'd you do it?
Thank you very much, Fiona, for that warm welcome. We've just been through an unprecedented journey in terms of being able to address a pandemic for the first time. And I would like to say to acknowledge all those CEOs and Aboriginal community health services and their workforce out there right across this country. We have over 143 Aboriginal community controlled health organisations that have worked remarkably well on the ground and at the local level to capture and to deliver the services that are needed. And our Aboriginal medical services are very much a trusted service that had to build capability and adapt very quickly to what we were about to embark on. I think it's really important to remember the strategies and the challenges that we put in place at the local level were expanded on, but they were also challenged up to and through our state peak bodies and affiliates, and then on to the national level, where we know that at the national level, the opportunity for NACHO to be able to provide guidance and advice to the Commonwealth Government is critical in this space in how we were to go forward. So we knew we had a really important role on the ground to ensure that we could protect our people, protect our workforce, and protect the services, because we had to continue delivering our services to households and individuals that are very vulnerable in our community, where we see many issues outside of the clinical domain into the social emotional wellbeing space. So we knew that we had to respond very quickly and adapt in all areas, in our clinical areas, in our communications, and getting this message out to our people, and also in our workforce and how we were going to look after the people that were delivering the services on the ground. You know, making sure that the early response planning, which allowed us to be ahead of mainstream in many places in regards to the hygiene and key messaging that we needed. And that early response allowed us to implement strategies for communication. In some organisations, Facebook played a very big part of this, our web pages, but the connections that we built were very robust. In Western Australia, we saw very quickly CEOs coming together through the peak body to ensure we had similar messages that were consistent throughout Western Australia, and that occurred also throughout the country. Very important, we had to, in a culturally appropriate way, deliver the strong messages, the guidelines and the protocols that were put in place by the Australian government to ensure that they were getting out to our people and to protect our people and to ensure the trust that we already had with our communities. We were able to facilitate and ensure that we could coordinate this so that, you know, with the very limited resources that we did have, we saw many issues that emerged that we weren't prepared and ready for. but we worked closely with others to ensure that we were able to implement and execute those messages and the policies that we needed to put in place to keep and ensure that we were able to follow those guidelines. But at the end of the day, be able to, protect the people in the communities, because we knew that if this got into our communities, it could have devastated the Indigenous community in this country. So I think we were very well positioned to deliver it. We just needed to ensure that, we had the resources. We did come together as a very strong sector here in this space, taking guidance from all the areas that we knew we had to and follow through, but ensuring that we did it in a way that our communities were able to reach out to us and we reach out to our communities to ensure that we had access to clients, to be able to work with the agencies where we're doing the screenings, to be able to ensure that the right messaging was getting out, because there was a lot of messaging in the space, and it was important that there wasn't, the messaging didn't get, wasn't, miscommunicated to our community. We had to ensure the continuity of care for our existing clients. So we saw the Aboriginal community control sector galvanising to look and secure resources such as further funding, submissions, looking to the leaders in this space. The Institute for Urban Health in Brisbane played a huge role in accommodating to assist with, services for isolated elders, the clinical and the communication information that was being directly delivered to the Aboriginal Community Control Services was absolutely critical for us to be guided by. And we also saw that, our role at the local level was critical. The pathways that we created for our guidelines and for the World Health Organization practices and the updates and the strict clinical assessment pathways were implemented. And we knew that our communities trusted us. And so we were able to go out there and advocate and be very clear, about many of the issues where we needed support. And we looked to the corporate sector. We also looked to government to assist us in that process. But there was a lot of work that was being undertaken, and many of the things we achieved were well ahead of mainstream in some aspects. So, making sure our workforce was continued to be able to deliver these really, really important messages. And what we do need to look forward to is how do we now go ahead and analyse this and have feedback from those communities about the work that was delivered. Played a very important role.
Lesley, thank you so much. Your leadership is just, that one thing you didn't mention was your own leadership. We'll now move on to Francine, the CEO of Derval Yerrigan. Francine, looking forward to what you have to say.
Yeah, the chairperson of Derval Yerrigan. Just want to acknowledge that we are here on the ancestral traditional country of Whadjuk Noongar people. I just want to acknowledge the extraordinary leadership of our CEO and medical director and all of our team at Derval Yerrigan Health Service. It was quite a rapid response. Like Lesley said, we had strong leadership and partnership with the Health Protection branch at the WA Department of Health, but leadership through daily communiques from the Aboriginal Health Council of WA in terms of what our responses should be in terms of COVID-19 and our response. We rapidly changed what our waiting rooms looked like, really stripped them back bare and ensured social distancing. And, our 4 clinics across Perth, we had staff outside of each of our entry doors checking people's temperature, encouraging good hand hygiene and, having a one-way path through our clinics and ensuring that people kept their distances from each other, but really reassured our community and made sure that our messaging was consistent So there were huge changes in terms of our infection control. People were separated, and there were stages throughout our clinics where people sat in terms of their journey through, in terms of accessing our GPs and primary healthcare teams. There was consistent messaging and training and upskilling of our staff in terms of what COVID actually was, and instituted into our policies and procedures. Our health promotion team regularly at Noongar Radio putting out those messages and updating our Facebook page. I covered our clinical flow changes in terms of infection control. There was suspension of all non-essential services and just making sure that our core service delivery was maintained. We were really proactive in terms of assistance to our vulnerable clients. We and SWAMS, through funding through IUE, now have a really intensive service in terms of taking our services to our most vulnerable and making sure that they don't slip through the cracks and miss out. So massive uptake of telehealth and phone consultations, and for the most needy, sending out GPs to them in their homes, but making sure that our staff, had adequate personal protective equipment. We stood down non-essential services and casual staff just to make sure that, we truly just focused on our core service delivery. Pregnant and immunocompromised frontline staff and vulnerable staff of ours, because many of our staff within AMSs have multiple chronic illnesses. So, those staff were able to work from home. But now we have all staff back on board. And fantastically, we were able to secure funding for 2 respiratory clinics, one in the northern suburbs in Mirrabooka and one in the southern suburbs at Maddington. And I can report that, the demand for those 2 respiratory clinics has been fantastic. So at least 50 clients a day being seen in those respiratory clinics. Yeah, so I just have some data that, so during the peak of the pandemic, there was an average of 205 telehealth consultations that were delivered, and over 50 vulnerable clients received home services, including food delivery from our welfare support team. Under an alternative model of care with strong screening practices, a daily average of 175 clients continue to access care across our 4 metropolitan clinics in Perth. So yeah, I think the key response was rapid and evidence-based practice in terms of the response.
Well, thank you. It's a huge area that you cover. That was fantastic, and I think the telehealth thing is going to be something of great interest. And I think what all of you are underplaying is the incredible success of the videos. With the health promotion videos on virus information, which are far better than anything we had for the non-Indigenous population. But Sandri, can you give us your perspective on this whole issue?
Thanks, Fiona. It's a great opportunity to look back. The first case in Australia was on about the 22nd, 23rd of January. February, it was grumbling away. And in March, we were just waiting and expecting we would do as badly as other countries in the world, and that Indigenous Australians would be similarly affected. I think what's complemented what's happened on the ground in places like Bunbury and Perth through SWAMS and Derbyl-Yerrigan is the existing network of national representation and activity that filters down through this network to these frontline services. So a big congratulations to Pat Turner and Don Casey and the leadership of NASHO with the Coalition of Peaks, and great people in there like their Chief Medical Officer, Jason Agostino. I think the representation nationally and locally and that network was really existed pre-COVID and was activated really effectively. James Ward feeds into the Communicable Diseases Network of Australia. Alex Brown and myself have a lot of involvement with the National Health and Medical Research Council, and we were both appointed members of the National Research and Advisory Committee for COVID-19 that the NHMRC activated. So I think at the Commonwealth level and filtering down to the states and territories, Aboriginal people and organisations have, carefully cultivated this system of health advocacy, representation, political lobbying, and it connects right down to these frontline clinics in local communities, local suburbs like Mirrabooka and Maddington, where Derbyl now runs 2 respiratory clinics. I do think we were really worried this might have a devastating impact. We know that in the usual flu season, that's difficult for older Aboriginal people with higher burden of chronic diseases and frailty that makes them more vulnerable to the impacts of these infections. And even for middle-aged people and younger people, the way the social determinants would be a barrier to Aboriginal people being able to leverage and protect themselves and their families if they acted on an individual level. It was really the activation of acting as groups of people, which is very strongly embedded in our culture. Groups of families, groups that coalesce to run community-controlled health services, and that network of working together as groups of state and territory peaks. And so the response included things like the urgent biosecurity measures to restrict entry to remote Aboriginal communities, the rollout and activation of gene expert testing machines so that there were point of care tests available in remote communities. But we also knew that a lot of our population lives in urban centres, and wherever there's an interface between our community and the rest of the Australian community, if there are outbreaks, we're vulnerable. And we're not really through it yet. We're through the first phase of this, and we're not sure how much it's the new normal. So how much, having got through that acute phase, it's not over. There's a way that we have to continue to work to protect families and communities and activate services. So, and still be able to roll out good preventative care, which is really the foundation of Aboriginal community-controlled health services, ensuring people get their flu vax, pneumovax, health literacy. I was amazed at how quickly the message filtered through the Aboriginal community, and just ordinary people we know suddenly cottoned on to coronavirus. They were quite comfortably talking about coronavirus in the community as well, and starting to get the implications of what that meant for them and others. And the work around health literacy was as important as the work around, health service delivery.
And that's a key point for Aboriginal community-controlled health organisations, ensuring that our mob are empowered about their health and their health efficacy, their ability to manage their multiple chronic illnesses, to one-stop shop that AMSs are is so important to our services' successes, I reckon.
Oh, look, thank you so much, Sandy. And of course, what you're referring to, Francine, is the trust. The fact that these services are trusted, they're not racist. Mainstream services are still racist and very difficult for many Aboriginal people. They don't feel accepted and welcomed in them. And I think that's a huge issue. And of course, we've had this most amazing Black Lives Matter, which is all to do with those sort of issues in our society. So Dan McCauley, up to you now to finish off the short presentations before we have the questions. Thanks so much.
Thanks, Fiona. Thanks for my double promotion, but I'm actually here working as the director of the Centre for Improving Health Services for Aboriginal Children and Families. So I'm really interested in that sort of health service area of this. So just want to reiterate what Sandy was saying, that we're still in the pandemic phase of the continuum. So we're not actually, I don't think, anywhere near that sort of transition phase into sort of recovery. But I think what for me, the most important thing that's been evident so far is the focus on this amazing relationship that's occurred between all of the community control sector and various state and territory and Commonwealth governments. And also I think the community response to this pandemic has been astonishing and amazing. And I think that, we need to continue that. There's some really great examples that I know of from Western Australia that have shown that really strong community driven leadership and activity. In the Fitzroy Valley, there was a really big push early on to get people back to community before community was locked down, and that was really successfully driven by actual community people on the ground there. So that was great. The work that was done here in Perth to provide accommodation for the large homeless population that we see in Perth, and I'm sure in other metropolitan areas. And they're a group that are incredibly vulnerable during this pandemic, and that was really a really rapid and great response. I think that what everyone said so far is that fantastic health promotion messaging that has occurred around physical distancing and hand washing. I think it's been it's been better than what I've seen in mainstream and from other countries. I think that's something that Aboriginal community control are very good at. However, I think that we have to realise that as we eventually move into the transition phase, which is around the recovery and preparedness for the next pandemic, is we need to do what we can do to ensure that the community-led response is maintained, so that there is a really good focus on being vigilant, looking at surveillance to make sure there's no sort of outbreaks, second waves, third wave, etc. And I think also during this recovery phase, we need to look at how the amazing rapid health service redesign that had to occur to protect our community. We have to look at what the unintended consequences and impact that may be having on the health of people. So we know that, with these rapid health redesigns, that we have these unintended consequences due to, the change, there's changes in health seeking behaviour, there's changes in health service delivery. We need to review how well we did and how to plan for the next pandemic. So looking at these unintended consequences is really about how we can do better next time and how we can sort of minimise the impact so far. And I think to do this effectively, we need to maintain this really strong relationships that have been developed, and that it's really been a whole of system response with community control leading, state, territory and Commonwealth health governments in this area. And I think it's a really good opportunity to utilise this to address other public health issues such as poverty, racism, the chronic diseases, and also the issue of justice, racism and justice that we're seeing now. So I think we've done amazingly well. We've done amazingly well if we look at, say, the Navajo Nation in the US, which have been really impacted. They have a rate of infection which is twice that of New York at the moment. So, and sort of the polar opposite. So I think we should be really proud of what we've done, and we need to keep it up, and we need to just drive it forward. Thank you.
Thanks so much, Dan. I think that's really important. I think what's coming through for me as well, and I'd be interesting to get Richard Dennis's comments on this, how cost effective is it giving Aboriginal people a voice, giving them power? I mean, this is unheard of, this success. It's the best in the world by a country mile. And it surely is. I mean, how many hospitalisations, how many intensive care beds, how many deaths have been prevented by this amazing leadership? And surely this has got huge implications for how we go forward. I think they should be congratulated. They covered every single area that had to happen to ensure this pandemic did not decimate them.
Look, absolutely. And, I was on a panel with you a couple of weeks ago, Fiona, where I first heard about this remarkable success. And I've been talking to people about it ever since. And, Australia's so used to hearing, it's wonderful, because we're so used to in Australia about hearing how Indigenous people have fallen behind, and we have some obligation to help Indigenous people. And all the nonsense that we have in our public debate, when inquiry after inquiry for decades has said, regardless of the problem, whether it's a health problem, whether it's an education problem, whether it's a justice problem, the first step is to sit down and talk to the community about their perception of the problem and their expectations of a solution, and get some genuine feedback before policy is designed. Worst case scenario from Canberra, best case scenario by the people involved in it. We've heard this for decades, and it's typically paid lip service. And what we've now seen is this remarkable success, not just domestically but internationally, remarkable success where, as you said in the introduction, groups that statistically should have had all of the risk factors going against them have outperformed the rest of the community. Why? Because the intervention started with a conversation. The intervention started from listening and respect and designing back from what the community needed. So from a democratic point of view, I just think that's the right thing to do. From an evidence-based policy point of view, it's the right thing to do. And finally, and lastly, from an economic point of view, it's cheap. Can you imagine? But that's not the reason to do it. This is just the benefit is we're treating people in our community with respect. We're listening to evidence about how to design policy. Oh, and by the way, that's the cheapest thing we could have done. Can you imagine how expensive it would be to run a health intervention in remote communities for hundreds or thousands of people in remote communities if COVID-19 had have taken off in those communities? It's incalculable what the cost would have been or what the tragedy would have been to not intervene in that way. So time will tell, but it's not just wonderful to hold this up as an example to say, maybe from now on could we do this in relation to all sorts of policies in remote communities and the Indigenous community in cities, as you said, but not only is it good, not only does it work, but particularly if we'd have had to deal with a large outbreak in multiple remote communities, it would have been beyond us.
Absolutely. And of course, there's no excuse now because there are so many outstanding Aboriginal people with training. We now have an Aboriginal data sovereignty movement, which every single person who's spoken today has been involved in, which means Aboriginal and Torres Strait Islander people taking control of their own data, and the results are extraordinary when they do that. And there's an Aboriginal Health Research Network that's proposed that Sandra and Dan have been working on too, which means that there'll be a galvanising, a collaboration across the nation of competency in Aboriginal health research. I mean, these guys know how to do stuff. And I mean, it's not just fire practices, it's health promotion. They're bloody good at it. So we need to listen.
Yeah, thanks, Fiona. And it certainly, is impressive to hear about not just the achievements, but the sheer hard work that went into it. I was just exhausted listening to that by the end. That's just a monumental effort. I did want to welcome everyone who's joining us today. We've had about 700 people log on, more or less, and I've got people from Noongar, Gadigal, Wurundjeri country, from Turrbal, from Marmu country in far north Queensland. So we've got people from right around the country. Thank you for joining us today. Just a reminder that if you'd like to ask someone on the panel a question live, you can use the raise your hand function, and I can see that someone called Jasmina would like to ask a question. I'll come to you in just 1 second, Jasmina. But my first question is from Chris Toomey that asks, how have staff coped with the additional pressure of COVID-19 and how have they been supported, recognising that many might also be caring for elders at home and hence worried about the risk of taking COVID-19 home?
Can I answer that?
Absolutely.
And this is from within SWAMS, and I want to congratulate all the staff at SWAMS for us in looking at how we address the workforce. All our staff had to undergo infection control training. This was an online training from the Department of Health. We introduced 2 days paid leave with COVID-19 symptoms to encourage voluntary disclosure, because we've seen in the media many times that people have gone in who have had COVID into places where vulnerable elders and others have been. For us, staff was directed not to attend work if they had flu-like symptoms. We ensured that we utilised our telephones and telehealth. SWAM's also introduced COVID paid leave to assist employees that were affected by COVID and their families. So we held daily meetings attended by staff, keeping them informed and up to date each day. All training that was face-to-face was suspended and shifted to online training. Work from home was encouraged. We had to draft policies very quickly to enable the flexibility here for staff to work from home. And staff were encouraged to work from home when their home was ready to do that as well. We ensured that change of clothing articles within lockers and bags were supplied to ensure that they had the proper PPE equipment whilst within the clinics, just to ensure that once they left the clinics that they were not taking any infections to outside the clinic. So very supportive of our staff because as an essential service, we had to continue to maintain to be open. We also had to ensure they played a very important role in reducing a lot of the anxiety. So ensuring that our staff were well trained and messages were conveyed. It was important that they was able to, do their work and feel that it was a safe space to be operating in, to come into work as well. One of the main things we looked at was the telehealth opportunities, which saw huge activities within our organisation with the engagement with the community. So the community saw that we were reinforcing these strong messages and protocols, and so they, that trust was continued as well. And very important.
Francine, did you want to add anything to that?
At Derbyl, we, switched. We encouraged, all clinical staff started wearing scrubs, big focus on personal protective equipment. We were cognizant that there was a lot of fear among the community about this virus before a lot of the education was rolled out and the messaging. So, we in terms of infection control, the hand hygiene training online, everything switched to online, and those key principles in terms of your PPE and infection control standards were implemented across all of our 4 clinics. The board agreed to 2 weeks COVID leave for anyone affected, and fully supported our staff and put across that you're our biggest asset. We're there to provide a safe workplace for you, and encouraged those with chronic illnesses and to take that leave that the board had signed off on. But very much one-way flow through our clinics. Every morning at each of the 4 clinics there were clinical huddles. Our medical director and executive management team, those key messages in terms of protecting yourself were reinforced on a daily basis at those clinical huddles. So very much our counselling staff were there to provide counselling regularly throughout the day to anyone who was concerned. And we know across our community there was so much fear. So, having our staff empowered and feeling safe in their workplace was such a, of strategic importance for our organisation.
Thanks, Francine. The next question is from Jai Dharma. Apologies if I've mispronounced that. This is absolutely wonderful, they say. Congratulations. And how do we apply the learnings from this success in improving health generally for First Nations people? And how can we support that good work? I might come first to you, Sandra, and then to you, Dan.
Ebony, I wonder if the urgency of this situation kind of stripped back the politics. There wasn't enough time for the politics to interfere with good, sensible decision making. You saw how rapidly we increased the New Start allowance, how rapidly we made childcare free. You know, nationally it was an environment where it was a major crisis. We had to respond quickly, and politics took the back seat to pragmatism and sensible policy making, and a lot of bipartisanship as well, and a willingness for everybody to pitch in and do their thing and make sensible decisions. So I've never seen this level of cooperation in my career ever. So I really hope that you know, there are ways we can not just, you know, flick back to our old way of doing things and playing the politics around Aboriginal health and empowerment of Aboriginal communities. And I really hope that that other things like telemedicine, some of the things that have been embedded quickly that will remain, can be supported and well used by Aboriginal health services and, you know, have direct and ongoing impacts.
Thank you. Dan, did you want to add something to that?
I'd agree. I think, you know, politics were put aside, issue that needed to be dealt with rapidly, saw everybody come together. And if we can maintain that, I think we can apply that to other issues. And I absolutely agree.
Thank you.
What about a voice? What about a voice enshrined in the Constitution and the Uluru Statement from the Heart? Yes, please.
No, it's a good point. We'll come to that in just a second. I've got a question from Jamie. Jamie, can you hear me?
I can. Kaya,
what's
everyone.
Your question?
I'm just wondering if anybody wants to speak to the risks that we face around funding at the moment. In that, my understanding is so much of this work actually was from the goodwill of the service providers and the workers. You know, like it was above and beyond. People were working 60, 80-hour weeks. There was a huge amount of grassroots activation and people in their own communities kind of delivering goods and services as well. What's the risk of the government saying, well, we did so well before, we don't need to increase funding, and you guys have kind of got it handled? Like, does anyone have any comments around that?
I think we've, you know, we'll be thinking and talking and analysing data and reviewing systems for months to years to come to really understand what's happened over the last 3 to 6 months. And I agree there's a risk that, oh, well, you know, even in the worst conditions, what you've got currently is sufficient. I think we've got to go back to basics and still, you know, fight the bigger fight, which is health equality for all Indigenous Australians. And there are some things we can take away from this acute and urgent situation, and that we need to take into account for, you know, the possibility of future pandemics in the short to medium term, not another 100 years on this scale. This may not be the worst pandemic we face in our lifetime. So I think we've got to still get on with business as usual things, and the advocacy and the activation and engagement of Aboriginal communities and people around adequate resourcing and a thorough and systematic approach to the whole Close the Gap campaign and the health equity targets. And I still think, you know, higher level issues around, constitutional change and all of those things are still on the table.
Richard, did you want to say anything about funding and costs there? What are the likelihoods that this success will be rewarded?
Or punished? Look, let me just reiterate, you know, what Francine just said is remarkable. I mean, in short, what a terrifying observation. We didn't have time to be racist. We didn't have time to be patronising in the rollout of policy. We just had to jump straight to what works. So, again, you know, congratulations to everyone involved in that. But, what a terrible thought that the Indigenous health community might be punished for its success. You can imagine it now, can't you? Look, see, you got through all that with what scant funding was available. Why on earth would you ever need more? Well, the answer is, of course, because the health statistics are so terrible for so many parts of the Indigenous community, and we need to roll out policies as successful as this across countless other health issues. We now know which ones work. We need to roll out multiple health interventions at multiple scales to address significant health disadvantage in the Indigenous communities. And if we do that, again, it's the right thing to do. It's also, in the long run, the cheap thing to do. But let's never make the case that we should do it because it's cheap. Let's always start with that it's right and it's fair and it's good. But yes, there is plenty of evidence that in the long run, it's actually cheap. What are the opportunities, Eb? Well, I keep telling people this. I know it's hard to hear. There is no budget constraint. There is no budget constraint. There is no shortage of money. Everything you've ever been told your whole professional lives is no longer true. You've just watched a coalition government announce $200 billion in new spending, and it's barely begun. So we are going to spend hundreds of billions of dollars in the coming years. We are going to. That's going to happen. We're just haggling about what. And at the event that I did with Fiona recently, I spelled out some criteria for what's good intervention. Put people first, go with labour-intensive stimulus packages, go to local communities where it's needed, and do things that have lasting benefits. Is there any more obvious candidate for good stimulus spending than labour-intensive health interventions in disadvantaged communities? Will that happen? Maybe, maybe not. Should that happen? Well, as a citizen, absolutely, and as an economist, what's the better option on the table?
Thanks, Richard.
I think that's fantastic. I think that will the coalition of peaks get this information and drive it? And Sandy, the fact that you're on the National Advisory Committee, so it seems to me that this is an urgent and wonderful opportunity to push on these issues.
Fiona, I think that what we highlighted earlier, that network of national representation and opportunity to really actually now start planning for the future months and years and how to lobby and advocate for a continuation of these systems. And it's great to hear Richard make that point about we've just taken the lid off and we will have to continue to spend to get out of the risk of a major and ongoing recession. And the spend in this acute phase was relatively limited. I wasn't impressed with any major funding announcement. A lot of this is, as you say, happened on very thin spending, but the activation of systems effectively, just because of the love and the care that these organisations have for the communities they serve.
The next question that I've got is from Sharon Holmes, and she asks, how can these strategies transfer to other issues that impact Indigenous people? And I was just going to have a word. We've got quite a lot of interest in the videos that have been mentioned, so I might track those down if I can, and we'll put links to those along with the video recordings of this. But I did want to put, I guess, all of this and that question in the context of the Black Lives Matters movement and the end to Aboriginal deaths in custody. Obviously, there's huge numbers of other health issues as well as social issues faced by the Indigenous community at the moment. So I'm not sure who wants to speak to that, but yeah, what are the opportunities here to transfer this very successful model into other areas of Aboriginal controlled services and service provision?
Ebony, can I just say generally, I was pretty amazed by the way Black Lives Matters popped up in the middle of this global crisis. It's as if the world had enough and oppressed minorities just cracked and said no more, we're not tolerating this. And they were in North America getting the worst end of the bargain, having the worst outcomes from COVID when that initially happened. But I always remember by 2030, there'll be over 1 million Indigenous Australians. And we're not isolated in Australia anymore because of globalisation, social media, the way in which it's hard to control the message globally anymore. It's not controlled by major media networks. There are these community-activated networks. So we're part of a community, a global community of minorities. So I don't think with the growing number of Indigenous Australians in this country that any of this broad local up to state, up to national advocacy is going away. I'm just so impressed that we have so many Aboriginal people in the National Parliament, both in the Senate and the House of Reps. And in state and territories. And I just think we remember marching as students in the 80s and, in the 90s. And I'm just so pleased that both at a grassroots level in the community and in an organised system way in government and NGOs and other parts of the country, I don't expect that advocacy to go away. And I hope the politics around this improves and we can see this as a demonstration of success and expect success in other areas.
Lesley, did you want to add anything to that?
It's an opportunity here to revisit the work we've been doing. Like we said, we're not out of the crisis yet. And however, I think there's a blueprint that's required here, for further situations that can be reviewed and looked at in other sectors. For us, it's about making sure that we've identified and understood the things that have been handled really well and the things that could have been done better as well. And making sure that we do a financial and economic analysis of the impact on our business and our sector. Can only act as, like I said, a blueprint for, other sectors going forward here and understanding the nature of that. And the feedback is critical from our communities in terms of, to see whether how successful that was or what success did it play in this part. And we know there are many areas in our communities across this country that we have to, now look at and step up and ensure that we've got the capability. Building the capabilities and injecting resources into this space is critical so that, this can flow on to make and look after the health and well-being of our Aboriginal people across this country.
Thanks, Lesley. Dan, I can see you nodding your head along there. Is there anything you'd like to say as well?
Yeah, unintended consequences aren't always negative. So one of the unintended consequences are some of the good things that have come out of this that we will be learning from. And one of the biggest unintended consequences is that now community control, community are at this table and can't be removed from the table now. So it's an opportunity to drive that leadership with these other issues. So, I think we've just got to onward and upward.
Dan, I did want to ask you about that, the unintended consequences, and you kind of talked about other health issues, including issues of justice and of racism. I just wonder for lay people on this webinar who might not be familiar with that idea, can you just unpack what that means?
So just quickly, we've been looking at what's been happening elsewhere. So we know that there's been changes in health-seeking behaviour because of the fear of going to an accident emergency or going to a hospital. So we know there's this negative sort of impacts from the outbreak. So we've seen a number of, in Italy, there's been a number of childhood deaths because of fears of taking children to hospital because of a condition that they have. So it's really around things that we didn't think of in the heat of the moment. So we know that children aren't getting face-to-face regular child health checks, so there may be issues down the line from this. We know that children may not be getting their immunisations on time, so we know that we may have some problems down the line with perhaps another small outbreaks of measles, etc. We don't know. Unintended consequence in the positive is this really great use of telehealth. So if we can take that forward, we can get care closer to home so people can have access to care better. So it's really the things that we don't know occur because of, the changes to deal with the pandemic.
And Francine, is there anything that you'd like to add to that? I might just come to everyone on that question.
Oh, look, I was just thinking, if there are health economists who wanted to work with us to write some papers, post this and, go through those lessons learned with us as an organisation for, preparedness for next time or the next stages of this pandemic, that would be appreciated. I always think to myself, any, major incidents or issues that occur within our service, regularly looking back and what were those key lessons that we learned from our experiences to inform future practice, clinical practice is something that's so important.
Thank you so much. I'm afraid we might have to wrap it up there. I'm terribly sorry. I can see a huge number of questions there that we haven't been able to get to, but I did want to thank in particular all of our panellists today. So thank you to Lesley Nelson, Francine Eads, Professor Sandra Eads and Associate Professor Dan McCauley. Thank you so much for your time today. And to you, Fiona Stanley, for helping pull this all together and for your wonderful introduction and observations. And to Richard Dennis, our Chief Economist at the Australia Institute. And thank you to all of you for coming along today and for all of those wonderful questions. This has been a special episode of Follow the Money, and we're aiming to bring you shorter but more frequent episodes during the pandemic, so please stay tuned, and if you can, leave us a review. It helps other people to find the podcast. For all the latest information from the National Aboriginal Community Controlled Health Organisation, you can visit nacho.org.au, that's NACCHO, or health.gov.au, or you can listen to the ABC's excellent CoronaCast podcast, which comes out daily. Join us next Wednesday for our next Economics of a Pandemic webinar series on navigating the Australia-China relationship with Professor Jane Golly, economist and director at the Australian Centre on China in the World at ANU. And she'll be in conversation with Alan Beam, director of the Australia Institute's International and Security Affairs program. That's next Wednesday, the 1st of July 2020 at 11 a.m. You can check out tai.org.au/webinars to register. And we're on Twitter at the Oz Institute with an AUS. My Twitter handle is Ebony_Bennett with a N-T. Dan McCauley is at Dan McCauley, MCAULLAY. Francine Eads is at Francine Eads, EADES. And Sandra Eads is at Sandra Eads. Richard Dennis is at RDNS_TAI, and this episode was produced by Jennifer Macey with help from River McCrossin. And our theme music is by Jonathan McFeat from Pulse and Thrum. And remember, stay 1.5 metres away, keep washing those hands, and thanks for listening.